Hi, just checking whether my audio is coming through.
Yes, Prashant. So loud and clear.
Uh, Harish, am I audible?
Yes, you are.
Oh, thanks, Prashant. Good afternoon, everyone. We appreciate that you have all taken the time to join us today for the Institute of Public Health Bengaluru's annual Oration 2024. This year, we are celebrating 19 years of IPH's commitment towards strengthening health systems. I am Arushi Thapar. I am a research officer with the Chronic Health Conditions and Public Policies Cluster. Let me start by sharing an overview of the activities planned for today. We will begin by talking about the ethos of the annual day orations at the Institute of Public Health Bangalore, which began in 2018 and have ever since been an integral part of annual day celebrations. After that, Dr. Prashant N. Srinivas, Director at IPH Bengaluru, will give us a brief overview about the Institute. We will then hear a bit about how our institute has been gearing up for the 20th year celebrations next year and launch the 20th year anniversary logo. And we'll then move to the oration that we are all eagerly waiting for by Dr. Soumya Swaminathan. Now that we've reviewed the agenda, I once again extend a warm welcome to everyone present in the IPH campuses in Bangalore, Mysore, and Chamarajnagara, and all our esteemed guests joining on YouTube Live. I would like to begin by giving some background about the IPH Annual Day Oration series. The series was launched in the year 2018 on the 13th Foundation Day of IPH Bengaluru. The aim of the oration series is to hear from professionals and leaders in the public health and development space about their journeys, their experiences, and contributions to the field. We at IPH see this as a day where we reflect on our practice, seek inspiration, and explore ways in which we can possibly do better and do more. We have had 6 orations since. The inaugural oration was delivered by Mr. K.V. Dhananjay, a distinguished advocate at the Supreme Court and various high courts in India. He provided a legal and constitutional perspective on public health and shared his experiences of engaging in several public health matters in court. In 2019, we had Dr. Ravi Narayan, a public health professional and activist who talked about promoting a shift in how we understand community health, from a biomedically oriented techno-managerial process to a social and community-oriented model. The 2020 oration was delivered by Dr. Geeta Sen, a distinguished scholar on gender, and she talked about the intersection of gender and health inequities. For our 16th annual day in 2021, we invited Dr. C. Madegaura, a social scientist and tribal rights activist from BR Hills in Chamarajanagar, Karnataka. He discussed various themes including health, education, and livelihood for Adivasi communities. In 2022, our oration was delivered by Dr. Rupa Devadasan, a physician, teacher, and community health practitioner who shared reflections from her 25-year journey in the fields of public health and education. Last year, on our 18th annual oration, we had Mr. Pranay Lal, an author and biochemist who worked in the field of public health, environment, and climate change. His oration delved into the interconnectedness of pathogens, the planet, and people. Recordings of all these orations are available on our website, and we encourage you to access them. Today, we are awaiting yet another inspiring oration by Dr. Soumya Swaminathan in just a few minutes. Before that, I present to you IPH's director, Dr. Prashant N. Srinivas. Dr. Prashant is a medical doctor and public health researcher focused on health inequities and social determinants of health. He leads a research group at the Institute of Public Health Bengaluru, which examines the intersection of health, social systems, and ecological factors. Dr. Prashant is an advocate for open knowledge, contributing to Wikipedia and other platforms like the Internet Archive. He also serves as the Vice Chair of the General Council of the Institute of Tropical Medicine in Antwerp. I request you, Dr. Prashant, to share with the audience about the Institute of Public Health Bengaluru.
Thank you. Thank you so much, Arushi, and dear friends from the Institute of Public Health Bengaluru, dear well-wishers, many of you who are joining and watching us on the YouTube live cast, and all others who may or may not know about the oration series or the work that we do, a very warm welcome to the IPH Annual Day Oration. My name is Prashant, and I'm currently serving a 4-year tenure as the director at the Institute of Public Health Bengaluru. It's an honor for me, as every year, to welcome all of you to our oration. In the next few minutes, 2 to 3 minutes only, because I know we are all eager to hear this year's orator, Dr. Soumya Swaminathan, who has just joined in as well. I'll give a very brief overview of the Institute and the work we do. Next slide, please. So the Institute is a bunch of us who are from multiple places across the country, and all of us gathered with a vision and mission for stronger health systems and trying to move us towards health systems that guarantee equity and that ensure health for all of us in the country. We work primarily from our head office in Bangalore, but we also have project offices in Mysore, in BR Hills Tiger Reserve, in southern Karnataka's Chamarajanagar district, as well as a few other project sites in Northeast India and in a few other states. Our work is primarily centered around research and action, which is one of the 3 main pillars. In research and action, we work on topics around health system strengthening, which lead to strengthening health services and health systems, especially for the poor and disadvantaged. We work on education, in which our work mainly is delivered through e-learning courses, through workshops, internships, and most importantly, a PhD program in public health, where we work with several international and Indian universities to develop a professional research workforce in public health for the country. And finally, we do outreach, which involves mainly engaging with communities on one hand, as well as engaging with decision makers, particularly in state governments and district governments and panchayats, in order to strengthen our health systems. Next slide, please. Currently, the Institute is organized along these blocks. We have a research group that works on health equity, where I am located. We have a research group that works on health financing and universal health coverage. My colleagues, Pragati, Upendra, and others are part of a research group on chronic health conditions and public policies, where there's a lot of work on tobacco control, but also on what is emerging as the commercial determinants of health. And we have several colleagues at the Institute who look at health services, looking at several different health problems, including tuberculosis and various other health conditions, and how they could be better served through stronger primary healthcare systems. Next slide. In our education, we have a bunch of e-learning courses, some of which are delivered in partnership with various other universities. Many of them are on the screen, and further details are available on our website. We have been working over the last few years trying to expand the offer of courses in what are called as health policy and health systems research methods, which involves looking at health from a very broad lens as opposed to only a disease-oriented lens. We have this newly emerging group of colleagues who are setting up Anubhava Shale, which is an immersive learning experience where we cater to people who are embedded into one or more of IPH's programs of work, where they either pursue higher degrees like PhDs, but also shorter term internships in one or other areas of work at the Institute. Next slide, please. And like I explained earlier, we have a very robust outreach, including a very strong grounded presence in southern Karnataka's Chamarajanagar district, where we work closely with several Adivasi community social movements, as well as districts' health and administration, in trying to learn as well as improve the delivery of primary healthcare services and programs. Next slide. So without any further delay, it's really an honor for our institute to welcome this year's orator, Dr. Soumya Swaminathan. I pass back to Arushi to take this forward.
Thank you, Dr. Prashant. Before we begin the oration, I'd like to take a moment to share that the Institute will be completing 20 years in 2025. We will be organizing events and activities to celebrate this, which we will announce through our various communication channels. We are in the process of writing a book that outlines the journey and experiences of people who have contributed to public health. Some of these people have worked at IPH Bengaluru in the past, and some of them are current staff members. We are also interviewing past and present members of the Institute, where they'll share their experiences, struggles, achievements during their professional journey. I am pleased to introduce our speaker for today, Dr. Soumya Swaminathan. She is a trained pediatrician and an internationally renowned researcher specializing in tuberculosis and HIV. She has held prominent positions as the Chief Scientist and Deputy Director General for Programs at the WHO. During the COVID-19 pandemic, she was instrumental in coordinating scientific initiatives at the WHO. She played a crucial role in establishing COVAX, which focused on ensuring equitable vaccine distribution to low and middle-income countries. Dr. Swaminathan has 30 years of experience in clinical care and research. She was Secretary to the Government of India for Health Research and the Director General of the Indian Council of Medical Research from 2015 to 2017. At ICMR, she worked towards integrating science and evidence into health policy making, enhancing research capabilities in medical schools across India, and developing collaborative partnerships in health sciences with other countries in the Global South. Currently, she is the chairperson at MS Swaminathan Research Foundation and principal advisor for the National Tuberculosis Elimination Program. On behalf of all of us at the Institute of Public Health, I'd like to thank you for taking the time out to be here and to address this gathering. As part of the celebration, we had our colleagues design a 20th year IPH logo. Since this event is happening virtually and we cannot do a grand unveiling in person, I request Dr. Swaminathan to officially declare the unveiling of the logo.
Yes. Good afternoon, everyone. Very good. Very good.
Thank you so much, Dr. Soumya. I now welcome Dr. Swaminathan to take the stage for the oration for IPH's 19th annual day.
Thank you very much, Prashant and Arushi. Good afternoon to you all. I can't see everyone who's in the room, but I'd like to first of all apologize for not being there in person. That was my intention, and I had planned to travel to Bangalore today. But at the last minute, there were some urgent things for which I had to stay back. So apologies for that. But luckily, we still have this online format that came out of the pandemic and that all of us have been using to stay connected. Now, what I thought I would do is really engage in a more personal discussion because having spent many decades in public health and particularly in health research and at the intersection of research and policy making, I felt that through my experiences, one could actually draw certain conclusions or learnings or lessons that may be useful for others. Because sometimes when you're in that, on the journey yourself, you tend to face situations, challenges, obstacles, which you think are pretty tough, and you wonder how you're going to ever overcome them. And there are always periods you go through in life with ups and downs, professionally and personally. But when you look back, then you can actually reflect on some of those moments and what could have been done better, or what could have been done differently, or what could have been certain changes in the ecosystem or the environment that perhaps could have made things a little bit easier. So, as you know, I started my career with the ICMR, but that was also interesting because after I finished my MD, I was very keen on research right from the very beginning, which is a bit unusual because not very many medical graduates, particularly at that time, this was 1976 when I finished, 1980 when I finished my MBBS. Research was certainly not an option that was ever talked about, discussed, or promoted. And at no time during my medical undergraduate training do I ever remember, though I went to one of the best medical schools in the country, Armed Forces Medical College, excellent facilities, excellent teachers and training. There was some research going on that one could find out about, but it was not talked to students about, and we never got any kind of exposure or research ethics or methodology or anything like that. So I think that hopefully should get corrected in the future. I don't know how much curricula have changed, but even during postgraduate, even though we did an MD thesis, I felt that was really not the kind of grounding that I needed. And so this is why I actually looked for a fellowship abroad that would allow me to find more skills in clinical research. So I ended up at the Children's Hospital of Los Angeles, where I, luckily for me, found an excellent mentor. And we had several faculty there that we could, speak with and so on. But the one that I started working with was Dr. Tom Keynes, who was a pulmonary physiologist. And his whole approach was to be such a strong research mentor that he took you from the beginning, from when you started thinking about a project, a question, something that interested you or that made you curious, that came out of the clinic. So you sat in the clinic seeing all these children with different respiratory diseases. And then in the afternoon, you thought about, what did I see? What is it? What is it that is still bothering me or intriguing me about those children that I saw this morning? Are there gaps in knowledge? Are there research questions? So you start from that, and then you build it into a proposal, and then you actually build the methodologies, and sometimes you're physically building the instruments that we were using, because some of the techniques that he encouraged us to use were very innovative. So for example, I wanted to look at the neural control of respiration in children, right? Because sudden infant death syndrome was a fairly significant cause of infant mortality in the West. It's never been reported to be in our part of the world. But there in the UK and the US, sudden infant death syndrome, particularly at that time in the 80s and early 90s, it was very, very important. And in the respiratory clinic, I used to see children with a huge variety of conditions, including something called central hypoventilation syndrome, congenital. I'd never heard of it or seen it. Now, these children live in the US because they get such good support, including home ventilation. The first time in my life, I saw children on home ventilation. And all sorts of mixed group of children with muscular dystrophies and muscular atrophies, neurological problems, Down syndrome, various kinds of things which ended up in respiratory failure and needed home ventilation. So a large part of my clinical work was on that. But yes, so I was saying we even built instruments to test ventilatory responses to hypoxia and to hypercapnia. We did sleep studies in infants, babies, and older children. And through all of that, would then take us through data analyses, through interpreting the results, to writing the paper, writing an abstract for a conference, actually going to a conference and presenting it, being confident to stand up in an international meeting and speak. So, I mean, to me, when I look back, it was only 2 years that I spent in Los Angeles, but it was such a complete and holistic training and building your leadership and confidence skills as a researcher as well, not just on the purely technical or academic side. And after that, I did 1 or 2 more years abroad and came back to India and ended up at the Tuberculosis Research Center in a way quite by accident. Again, serendipity, I suppose. I met someone who said, oh, you should, you want to do respiratory research, you should go meet the director of the Tuberculosis Research Center since you're in Chennai, ICMR Institute, one of the larger ICMR institutes. So I ended up there. And again, I was fortunate that I met someone, Dr. Vijayan, who was interested in adult pulmonary physiology. And he said, in fact, I've been thinking about pediatric and wondering who I can recruit to do more pediatric work. So that's how I made my entry into the TRC, not to do TB research necessarily, but to look at other respiratory diseases of children. And I looked at bronchiectasis. I did some very fundamental work on estimating the aerobic capacity of children, of girls and boys, and linking that with nutrition and linking it with sexual maturity. So that was for the first time, started doing bronchoscopies and bronchoalveolar lavages along with the faculty at the Institute of Child Health. So I had to go and make connections there because I didn't study in Chennai. So Chennai was really medical fraternity. I didn't have teachers and professors I knew. But I found a very good group at the Institute of Child Health who was research-minded. Again, lucky to meet someone, it was Professor Somu, who was setting up the whole branch of pediatric pulmonology at the Institute of Child Health in Chennai. And he felt that, yes, research should be an element of what we're doing. And so it was an excellent partnership because in the mornings, I would go sit in the clinic with them and see patients, including TB, of course. And then in the afternoon, I would come back to the lab and do some of the analytical work, either with bronchoalveolar lavage samples, or sometimes I would actually bring children back to do some lung function testing and all that we could not do in the hospital. I enjoyed that phase because it gave me a chance to still feel connected to the clinic, because I feel that that's where a lot of the questions come from. So of course, if you're a health system researcher, you need to be immersed there. If you're a clinical researcher, you need to be in the clinic. And very often our research institutes are designed in a way that you're cut off. So you say you're a researcher, but then you don't know what's happening in the clinic. And you say, I will only do research. And the clinician says, I will only do clinical care. And similarly, the teachers are doing teaching. Whereas what I found in the US and other countries is you can do all three. You have time allocated to them throughout the year, and you have protected time for your research. Of course, you have to raise your own funding, grants, etc. You also have clinical duties when you're really busy on the ward, and then you have teaching. That keeps you, I think, up to date, both with the reading and also with engaging with clinical problems and engaging with students, which always, again, I think is very good. So there's a design fault in the way our research institutes are, some of our research institutes, or many of them, are set up, where they become ivory towers and are not connected. So when I started working there, I found that it was a very good environment, because you had the clinic with physicians, and then you had, many other departments, epidemiology, who did the field work, and they did many of the classical studies like the BCG trial in Chengalpet, and the subsequent, long follow-up of people in the community, etc. So you needed a team there on the ground to do that. We had the microbiology department, which was a WHO, accredited lab, a center of excellence for TB microbiology. We had biochemistry, we had pathology, and immunology, and so on. And immunology was at that time basic, but then it kept improving with improvement of techniques. So I felt that you could really do kind of a very multidisciplinary kind of research into TB, where you did not only have to rely on the clinical findings, but you could get a lot of backup support from all of these lab supports that we had. So I started doing a lot of pharmacokinetic work. So though I was trained as a pediatrician, I found myself in an institute that does TB work, and therefore I did adapt myself to that, and did not restrict myself to pediatric TB, but decided that I would engage with the problem of TB as a whole. And of course, at that time in the 90s, HIV was becoming a problem in India as well. It was recognized, and TB, HIV was actually the major complication. It was the presenting illness in most HIV infected people. It was mostly the cause of death and a lot of suffering. As you may not remember, many of you are too young to remember, that there was a huge amount of stigma associated with HIV. At the beginning, a lot of fear and reluctance to have anything to do with these people, including, unfortunately, in healthcare settings. And I saw so much of stigma and discrimination in healthcare settings at that time, with these people, patients who are HIV positive, being sent from pillar to post because nobody wanted to, especially if it involved any kind of intervention, surgical intervention, admission. Extremely scared. And the Tambaram Sanatorium became the kind of place where they all ended up getting admitted. And that sanatorium, from a TB sanatorium, it turned really into an AIDS hospital, very seriously ill, advanced disease, and the whole hospital. I will not forget those days when every bed was occupied, by a skeletal, bone-thin person with some complication of HIV. And I must say that spending a few years working with those patients there, I saw so many different clinical manifestations of disease. I mean, cryptococcal meningitis and all one has read about in books. But every day you would diagnose cryptococcal meningitis. You would, of course, have a lot of candida. You'd have all sorts of pulmonary infections, including pneumocystis. And it was like a textbook of medicine. And you had to be on your toes and learning all the time. And then, of course, we were also surrounded by death and dying, because very often these people would improve after anti-TB treatment, but would very quickly deteriorate again because their CD4 counts had been falling. And it was a temporary lease of life they would get. And they would be so optimistic. They would put on weight. They would recover their appetite. They would really feel like they were getting better. And then, unfortunately, very soon after APT had been completed, they would deteriorate again, or they would relapse or get a reinfection with TB or with some other infection. It was a huge, I would say, a mental toll as well on the team. And was interesting because there were very few staff who wanted to work with me on HIV. So my director called me one day and said, this is an area which is growing in India. There doesn't seem to be any other center doing this work on TB, HIV. Why don't you take it up? And I said, okay, I need a team. And so I went around asking people, will you come on to my team? And I got exactly 5 hands out of the 500 staff members there who raised their hands. So I, 2 or 3 social workers, 1 nurse, 1 lab person, an immunologist, and then we had support staff, and a driver and a jeep that took us to Tambaram every day. And by immersing myself there, I also was able to generate the kind of research questions that one would need to answer on the duration of chemotherapy. In those days, we were giving alternate day anti-TB treatment. That was a standard practice in India, DOT. Does that work? It wasn't working. There was a lot of acquired rifampicin resistance, a lot of failures, high mortality. We did blood tests to look at, and we showed that rifampicin levels are extremely low in people who are HIV infected, and moreover, if they are malnourished. And even TB with malnutrition, you find low rifampicin levels. Drug interactions, we looked at nevirapine, efavirenz with rifampicin. So we did a whole host of studies at that time, and South Africa was the other place where such research was going on. And our group in Chennai, and we would be presenting work that was very complementary at many of the international AIDS and TB conferences. Now, through all that, I think the social aspects, social science, the need for social science and behavioral science became very clear to me as I worked on HIV and also TB, because it's not just the biomedical aspects you have to look at and look after, but you have to really look at the person and their social and environmental and economic environment, and deal with all of those things. And many of them needed legal support. They needed, schools for their children. They needed to go into an orphanage or a rehabilitation home. So all of those, and then, we had to do advocacy. We had to work with state and central governments, and that's where the intersection with policy, I started getting into those conversations, both at the state government and the central government level, where you had research findings and you wanted them to be considered for policy making. And it was a very tough path, because the policymakers have a very different way of looking at things, right? And the way you present your evidence and the way you make your case is sometimes does not strike a chord with them, even though you may think that this is the most important research finding and that it's really going to have an impact. But I found that the policymakers are much more receptive when you've had a discussion with them about the problem at hand, and then you're trying to then come up with a solution, or even better, a menu of solutions. So sometimes one solution is not going to cut it, but if you have a menu of options, it's much likelier that somebody's going to pick one of those. You also have to be persistent. You have to accept a lot of, I'll say, being ignored or being, just not taken seriously, etc., etc. And so I think that, it takes a lot of time, effort, and teamwork to do good research. But then for it to have an impact, it's even more tough. And that's where I think my director and other senior people at that time were very supportive and helped me navigate those corridors of power. And I'll come back to this at the end. But I just want to finish this section by saying that as far as tuberculosis is concerned, I sometimes feel happy and sometimes feel very despondent, because over the last 40 years or so that I've been working, the world has made amazing advances in science and technology. In every aspect of life, you see transformation. And in TB also, to some extent, we can't say we have not made progress, We've now got, the molecular diagnostics that we did not have when I started off. It was all about smear microscopy and how to improve smear microscopy. We have better drug regimens now, though we don't have that many new drugs, but we have at least been able to shorten the duration of treatment, especially now with this so-called BPAL-M regimen for MDR-TB, that's bedaquiline, protomimid, linezolid, and moxifloxacin. And there are some more latest trial results that have come out for the management of very drug-resistant MDR, XDR, and so on. And in the case of drug-sensitive TB, despite all efforts, we have not been able to successfully reduce. In fact, the main goal of the trials conducted at the Tuberculosis Research Center was to shorten chemotherapy progressively. Of course, starting from the 50s when it was an 18-month treatment and then coming to 6 months. But below 6, there have been trials showing 4 months you can use certain combinations, including the trials done here. And the trial now WHO recommends rifapentine, INH, moxifloxacin, and pyrazinamide as a 4-month regimen. But that's very, very incremental kind of progress. We've not revolutionized TB treatment by saying, hey, we can cure it in 15 days or a month, which would be actually the solution. And then, of course, to have a point of care test that you could do, either a self-test or some other kind of rapid test that a health worker could do. We're getting closer, but we're not there yet to having a test like that, the tongue swab, like we have for COVID with nasal swabs. And of course, a vaccine, the holy grail for infections like TB, HIV, malaria, all intracellular infections has been vaccine. We've had some progress with malaria vaccines. We now have 2 WHO-approved malaria vaccines, both for falciparum, HIV vaccine, no, and TB vaccine. Again, we have some in the pipeline, including mRNA vaccines now that certain companies are trying to make. MTB vac, we have the M72, but none of them, of course, we have to wait for the final results to come out of the definitive phase 3 trials. But the progress is slow, you see. So we're still relying on BCG given at birth, which we know has limited duration of protection, and that too for extrapulmonary TB. So whether it's diagnostics, drugs, or vaccines, we have challenges. And unless we have these new tools, the NTB goals reduce by 90%. The incidence of TB by 2030 reduced by 90%, the mortality due to TB, and go to zero catastrophic costs, because TB is still accounting for a lot of catastrophic health expenditure and pushing people into poverty. So these are the 3 major goals, and the ways to do it really are through individual patient-centered care, where you actually get everything about that patient's needs need to be taken care of. And so the Indian program, the National TB Elimination Program, is now looking to have something called differentiated care, which has been piloted in Tamil Nadu and a few other places, where you don't look at that individual as saying you're a TB case, but you look at him as a person or her. Do you have hypertension? Do you have diabetes? Do you have anemia? Do you have malnutrition? Do you have electrolyte imbalance? What is it that you need to get better? Not just the TB drugs, but a whole package of clinical care. And unfortunately, with the verticalization of programs, this type of holistic approach is lost. TB is not included in the PMJY packages. Many hospitals deny admission to TB patients, saying that there are no beds for TB. Malnutrition is not managed. The other complications are not managed. So we still have this huge mortality. And that is what I feel most despondent about. That in so many years of having a TB control program and then a TB elimination program, that we still have a mortality of about 350,000 people dying every year, which means 1,000 people a day. And this is what I used to say 20 years ago, that we have 1,000 people a day dying, still 1,000 people a day dying. We have failed TB patients. And so, as principal advisor to the program, my first and foremost priority and goal is to reduce mortality. And that requires multiple interventions, of course, and does require a multi-sectoral approach as well. So that would be my first priority, and then would be, how do we make sure that every person with presumptive TB is diagnosed early, timely manner. The TB prevalence survey that was conducted by the ICMR, again, after a gap of 50 years, 1955, India had a national TB prevalence survey, and then again in 2019. Unfortunately, the pandemic interfered, but still the survey was done by 2021. It was completed. And the results are interesting because firstly, it shows that we have prevalence of over 300 per 100,000, again, very high. Secondly, it showed that 40 to 50% of the cases detected, the bacteriologically positive cases, that is microbiologically confirmed, were asymptomatic or had such minimal symptoms that they had not sought. So there's a huge population of people with subclinical TB who are currently not being picked up at all by the system. We do have active case finding approaches, but not sufficient. We really don't know which are the best protocols to use. So there's some science there to be done on how can we find the maximum number of TB patients in the community, of course, in the most cost-effective way. And then, of course, they all have to be linked. Treatment. And then how do you protect others, household contacts, other contacts? And the other thing that the TB prevalence survey showed is that the top #1 risk factor for TB was undernutrition, and work done by Anurag Bhargava and others in the past has shown that malnutrition or undernutrition contributes to about almost 50%, 48% or so of the TB burden in this country, followed by diabetes, alcohol, smoking, and HIV, which is not that significant, in India. And so malnutrition is prevalent, and therefore, and diabetes is growing. So these two risk factors for us are very important. Smoking, probably air pollution also playing a role, though not really documented that systematically. And so this phenomenon of subclinical TB might be contributing to the fact that we're really not being able to bring down our incidence, even though our case notification has been going up. And after the pandemic, it's picked up again. Last year, 2.5 million people were notified. This year, maybe even more than that. But obviously, that's still only the tip of the iceberg. And then there's the private and public sector in our country. So when you have a big public health program like this, you have to take both along with you. So those are, I think, some of the remaining challenges, and hopefully we get, to addressing them. And accelerating the progress towards the elimination goals. We're still quite far away. The second component of what I wanted to talk about today was about the experience of COVID, the learnings again, what worked and what didn't work. So really look at it in maybe 3 buckets. The first bucket being public health and primary health care, the role that played. The fact is that when you look globally, the countries which really had strong public health systems, especially good primary health care, had invested in community health workforce, actually ended up doing better, even though they may not have been the countries with access to all the latest technologies. So countries like, Thailand, Cambodia, Senegal, Rwanda, they did relatively better. The second was that countries which used science and technology and scientific methods to put in place, the strategies. For example, Korea very early on decided and that it was diagnostics, testing, mass testing, test as many people as possible, and then you can identify, you can isolate, you can quarantine the contacts, and you can stop the spread. They were very successful. Remember, in the early part of the pandemic, South Korea was one of the countries who was massively testing because they already had that capability in doing high throughput diagnostics. And their companies immediately made the diagnostic kits and made them available to government. There were other countries which had absolutely no access to diagnostics. Most of Africa could not test. They did not have the labs, they did not have the kits, they did not have the human resources. And so it looked as though Africa was not affected by COVID. But actually, when you look at sero surveys, same proportion of people got infected there also. By the end of 2021, you found, 80-90% are having antibodies. So it's not like people in Africa didn't get COVID. They did not test and they did not confirm. And if people die, you don't know what they've died of. What was beneficial in their case was that their median age is extremely low. So the median age across Africa is about 18, 19. In India, it's about 28. In Europe and Western Europe and North America, it's about 44. And this is why you saw the high mortality among the older populations in Europe, North America. And you saw relatively less mortality in Africa. But it's not that they were not affected. So if you don't test, you're not going to find. Many Indian states also, had comparatively much lower testing compared to other Indian states. And so you could see these differences in reporting of cases and reporting of deaths. So the system of, testing and reporting and notifications needs to be strengthened across many states. And I think that in terms of being able to roll out the public health interventions, India was relatively doing well because you had community health workers, you had people, of course, taken from all other programs and put into COVID so that they were keeping an eye on people who were infected, making sure that you were taking, you were isolating at home, tracking your contacts, using apps. All that was good, but then all your other programs suffered. Your antenatal and postnatal care, your immunization program, your NCD program. So across the world, the WHO did a series of surveys across many countries. About 100 countries used to participate in these surveys every 6 months to see which public health programs were impacted, and practically all of them. And the lower the income of the country, the more broadly their programs were impacted and the longer it took for recovery. So the health system's resilience was tested by COVID. And of course, a lot of staff was, brought on board, recruited, moved from other sectors and so on. But I think that's a lesson to learn that in the future, we're going to face these shocks. And these shocks could be infectious disease shocks, or they could be climate disasters and hazards, etc., natural disasters. And so the health system has to build in that resilience to be able to deal with these emergencies. The second area was around science, and I was very much involved with that as chief scientist, helping to coordinate globally. So many expert groups. We had hundreds of expert groups working on all different aspects of COVID. We ran a research and innovation forum in February of 2020 itself. Within a month or 6 weeks of knowing about this new disease, to lay down a research priorities and to lay down a roadmap that can guide the world. And with that, what ended up happening was that many different action groups were formed, and those groups then had subgroups. So experts from around the world, I've never seen such collaboration, such willingness to share and learn, and such willingness to work without consideration for any kind of returns or rewards with the WHO. And because of that, we were able to put forward, everything that was happening, new information that was coming through, new knowledge, updating all the time of course, following the vaccine development. And for that, we, again, very early in April of 2020, we had already made the target product profile for COVID vaccines. Those target product profiles were accepted by regulators around the world, so that when the FDA or the EMA or anybody was looking at a vaccine, they were using the same benchmarks that were published by WHO in early 2020. We speeded up, of course, emergency use authorization. So there was work happening across, and as the science division, we were helping to coordinate all of that. But we were also fighting misinformation and what we called the infodemic. That, unfortunately, is here to stay because of pervasiveness of social media, the fact that everybody uses social media to get their information. We can, of course, get a lot of information from social media, but you also get a lot of mis and disinformation. And there are groups of people who are out there just, doing that. That seems to be their main job, is to spread disinformation. And they were spreading a lot of that about vaccines and creating vaccine hesitancy. Many countries actually did suffer. Luckily, not India, but many countries had vaccine hesitancy as a huge problem when they tried to roll out, COVID vaccines. And then, of course, we were also looking at, once the vaccines, we knew that they would be available. Even before that, we had developed an equitable access framework where we had convened all the countries and said, this is how we should share vaccines around the world. Let's try to prevent as many deaths as possible, etc. But all that was accepted theoretically, but in practice did not happen. And so we ended up with a situation where countries which had access to vaccines, because they were able to pay in advance to companies and block doses, or they had their own manufacturing. These two groups of countries were okay, and the rest had to wait in line for a very long time. And that resulted, of course, in a lot of tensions, geopolitical tensions, but also sort of loss of trust, particularly from the African continent, which suffered the most due to the lack of access to vaccines. So we set up COVAX actually to deal with or to try and prevent this from happening. And I would say that COVAX was partially successful. Why? Because without COVAX, probably things would have been even worse. So at least the fact that 2 billion doses of vaccines were distributed, to low and middle income countries by the end of 2022 or so, it was a remarkable feature which had not happened in the past. There's never been any such attempt made. But of course, on the downside, we could not do it early enough. So in 2021, when vaccines were really needed to protect the vulnerable, many countries were not getting access to it. Now, because we also saw that the behavior of companies which had access to new technologies like mRNA and their absolute refusal to share the technology, even though they knew it was life-saving if they had shared it. Many more companies, probably Indian generics, could have started making more vaccine early on. We decided then to launch the mRNA technology transfer program, which enabled or which basically built an ecosystem of scientists across 16 low and middle income countries working together to develop mRNA products. And very quickly, they were able to replicate the Moderna vaccine. But of course, a new vaccine has to go through, all phases of testing. So we knew it would not help during the pandemic, but it would help to build the capacity and set a precedent for a different way of a model of R&D, where it's not private sector profit-driven model, but more a public health model, where if a team develops a product which is successful, which is efficacious and safe, you then share that IP and share the technology with groups around the world through a transparent and fair mechanism like the medicines patent pool, which was used, still used, set up for HIV, expanded to TB and I think further expanded. But a mechanism like that, and MPP actually became our partner with WHO, so it was Medicine Patent Pool and us who initiated, were able to raise some funding, set this group up. And I'm very happy to see that they're still very active, successfully developing vaccines and therapeutics using mRNA against a host of diseases, not only communicable, but also non-communicable diseases, cancers, and so on. So I think the technology has huge potential. It definitely was tested during COVID and found to be good. But now the question is, who's going to have access to it? And will it make a difference for the health of everyone, like what Prashant was saying at the beginning? The goal is, if you have advances in science and technology, like gene therapy, for example, right? So people in America, okay, still few even over there are getting cured if they have sickle cell disease or thalassemia. But we can't even hope to bring that at scale in India just because of the costs. And therefore, we need to build that capacity, and we're very good at affordable innovation. But that ecosystem, if it is created, and there has to be both a push and a pull factor there, but the government has to provide, funding and support for this type of research. And what they get in return would be these products, which the private sector may develop or the public sector, and you often need both, but which is then made available and accessible, at a reasonable and affordable cost. So I think that kind of collaboration did happen during COVID, but it happened because it was an emergency and everyone was so desperate. That needs to become a routine for all of our major public health problems. And that way, we'll be able to move towards universal health coverage and access to medicines, not just for very common conditions and diseases, but including for some of the rarer conditions or things like cancer, things like, some of the hereditary diseases for which there are now gene therapies, but not widely available. Similarly, I think devices and assistive devices, for example, for an aging population, one is going to need a lot of things to support, starting with spectacles and hearing aids to canes and wheelchairs, walking device, and all kinds of other things as we get older. And unfortunately, the prevalence of neurodegenerative diseases is going to increase. We've also got to think about not just the young children, but also now the other end of the age spectrum and how we're going to cover them as part of universal health coverage and take care of their needs. So there's a whole lot of lessons we can learn from COVID at the global level and collaborations that are needed and geopolitics of that, and the fact that we still don't have a negotiated pandemic treaty because countries are not able to agree on certain equity principles. But then coming down to the national and subnational levels, how do you actually manage your health system and without putting an unnecessary strain on few people, but at the same time also making sure that your routine health services don't get impacted. And then the innovation side of it, how do you promote affordable innovation? And for that, you need a very robust R&D ecosystem that is promoting a lot of basic science and basic research, because without that, you're not going to get products. So maybe I will close that chapter as well, so that we leave some time for some interaction, but then come to the third part, the final part, what the remarks I wanted to make, which is around being a woman and a woman scientist or a woman physician or somebody trying to do public health, and what are the barriers that I faced. I must say that I was, I think, relatively fortunate in that I can't say that I had a lot of bad experiences, but What I can say is that we still live in a patriarchal system. We still live in a hierarchical environment. And so if you are young and if you're a woman, then chances are that you won't be taken as seriously as somebody who's older and who's a male. And this may be just, this is not unique to any country. It is actually global. And there are lots of data and statistics out there about leadership in health institutions. Even at the global level, you'll find that women are there in less than 20% of leadership positions. I mean, if you look at political system also, majority of countries have 10, 15, 20% of parliamentarians are women. I think we're somewhere around 14%. If you look at domestic health institutions, health professional bodies, again, you'll find that women occupy less than 20% of leadership positions, even though the bulk of healthcare workers are women, right? So the nurses and the community health workers and everyone. And more than doctors, I would say that it's those cadres which have even less opportunities for career progression, as well as for their voices to be heard on the decision-making tables. So that is something that we have to consciously work towards changing. And I know that places like IPH are very different, that you have, that you work very closely with communities and in a participatory way, joint decision-making and so on. But when you talk about policy making and so on, that doesn't happen as often as it should. And even in the TB program, one of the things we will do is really try to have a much more robust engagement with the civil society and with affected groups like patient survivors and so on. So I think that brings, so having men and women at the table, and not just men and women, but from different backgrounds, different geographies, different socioeconomic strata, different experiences, it always adds value to the discussion. So for example, here at the MS Swaminathan Research Foundation, whenever we have a scientific meeting, we always insist on having the stakeholders who are, in this case, farmers, tribals, fishermen, fisherwomen. And I was amazed, how confidently they speak. Even though the scientific conference may be going on in English, they speak in their own language. But the points that they make are points that no one else has thought of. None of the scientists and academics in the room have made the points that the farmer, especially the woman farmer who spoke at our latest conference, and a woman fisherwoman who spoke. They both just made, absolutely relevant and practical issues, especially for the policymakers. So it's so important for those voices to be heard, to be amplified. And therefore, we believe that knowledge is an experience, two-ways process. And what we can learn from the communities, we must take them up to the table where decisions are being made, and vice versa. Whatever government is deciding or making new programs and things like that, that information must flow back, because very often there's a gap there. The person on the ground really doesn't know that actually there are so many schemes and things which could be benefiting them. So NGOs play an important role here, I think, in making this connect. And it has to be two ways, I believe. But I also think that women's leadership is so important. And so I'm part of a group called Women's Lived Health that provides leadership training to mid-career women. And we now have a third cohort in India, I believe. There's a North American cohort, an Indian cohort, and an East African cohort. It's expanding. And the program has, people who've been through it have had very positive feedback on the program, because it connects you to peers. It gives you certain skills. It teaches you how to deal with some of the challenges you face as a woman in a professional career. And it also, over a period of time, hopefully will start having some institutional impacts as well. Sufficient number of women are trained and heads of institutions are sensitized. Then we can hope to start getting those gender-sensitive policies. Even simple things like, do you need a creche in your workplace? If you have enough women working there, are you taking care of rooms for breastfeeding or other needs? needs of women, needs of, maybe disabled people. So how do you create that inclusive environment? And you need to have a little bit of that switch in thinking, which often is, is missing in the routine humdrum of the way things get done, particularly in government. So it's important to keep reminding ourselves and reminding others that it's important to be inclusive. And therefore, I know many people now, many very distinguished men colleagues who refuse to be on manuals, and take a principled stand against that. So, of course, a woman should not be invited just, for the sake to fill that slot. We have to have a woman on the panel. But the fact is that there are enough women in every profession, distinguished enough as their male academic peers to be invited on to speak. It's just that sometimes they are invisible. And women also don't come forward as forcefully as men do. Sometimes men put themselves forward for roles which women would be thinking 3 times about. And this is from my own experience. I can say that a woman often underestimates herself, and she feels maybe I'm not yet making the cut for that job or for that role. Whereas a man, exactly with the same background and experience, would very confidently go forward. So I don't know whether that's something to do with societal upbringing or what it is, or it's just innate nature, but it does happen very often. And women need that little bit of extra encouragement from someone that they know, a mentor or a peer or a colleague or somebody in the family, to say, no, you should try for this. And so that's often the reason why you may not even find women applying for things and saying why I want to have a level playing field, but I'm not getting that many applications. So again, we have to encourage our young women also to be ambitious and to be confident and to want to put themselves forward. Of course, you're not always successful. So when you compete, somebody wins, and everybody cannot win every time, but that experience of going through that also is very good, I think, for building some of your skills. So I think I'm going to just stop there. And Arushi, I don't know if you want to take it over from here, or Prashant, but I want to thank you all for giving me, I think I've spoken long enough. So I'm happy to take maybe 1 or 2 questions or comments if you like.
Thank you, Doctor. I think most of our participants are attending via YouTube Live, so that's not a very interactive sort of platform.
Right.
Yeah, I think we'll move on to the next bit. Thank you, Dr. Swaminathan, for sharing your reflections. I'm sure many of us public health professionals can take away from your personal sharing and broaden our vision across disciplinary boundaries in our journeys. As I mentioned before, this oration and our past orations are available on YouTube. Please feel free to share them in your networks. I now invite Dr. Vaibhav Agavane, Assistant Director Outreach, to deliver the vote of thanks.
Thank you very much, Arushi. Am I audible well, Arushi?
Yes.
Yeah, thanks for that. Before I deliver the vote of thanks, I would like to just share, after listening to Dr. Soumya Swaminathan's reflections, that it's really wonderful that you chose to share your journey, because for public health professionals like us, we often get to hear about orations or talks which are very specific on, let's say, disease like HIV, TB, but we not often get to hear journeys of professionals and leaders like you. So thank you very much for that. I also realize, as you were sharing your journey, and some of the colleagues who are with us in the office sort of sounded that it's nice to know that how scientists like you, through your journeys, have sort of changed things and practiced science, and that sort of makes things very relatively easy for younger generations like us. And third reflection that I realized after listening to you, that science practice and decision making, etc., sort of need not happen in silos. They are very much sort of interconnected and need to work with each other. So I thought I would share some of those reflections based on your sharing.
Yes.
Yeah. I thank you very much, Dr. Swaminathan, for agreeing to deliver this year's oration for the institute. I also thank the organizing team members, support team members, some of the colleagues from the institute who extended their support towards this event. At the end, I would also like to thank all the staff of IPH who have joined in person to listen to your oration at various offices that we have for the institute in Chamarajnagara, in Mysore, in BR Hills, and also in Bangalore office. I would like to thank all the esteemed guests and participants who have joined online for this oration. With that, I bring this event to a formal close by thanking everyone. I request our IT team to sort of close this event formally. Thank you very much, all of you, for joining.
Thank you. Thank you, everyone.